across the two hospital sites. But I would like, just before the board meeting gets going, to particularly thank the executives and senior managers who have been working relentlessly hard to get the shared leadership model to work. I'm sure Adam and colleagues will pick up on some of the early successes we're already having of bringing together the two teams and two organisations. I'd also like to thank Vanessa and Sarah Collette for their work in pulling together the board pack. The board pack is a little slimmer than it was last month, but it's on a bit of a journey to reach its final destination as we bring the two reporting mechanisms together. But I know for Vanessa and Sarah, it's particularly hard work. And so if colleagues can ensure that they bring their board papers on a timely fashion, that would be wonderful. So we have apologies from Paramjit Gill, Sarah Raystrick, who hopefully will be joining us later, and Yasmin Becker. Do we have any other apologies, Sarah?
No, Russell.
Okay, so without further ado, the minutes of the meeting held on the 7th of October. Were there any points of accuracy? If you could raise a digital hand for me, please, that would be great. Okay, I can't see a digital hand raised, so I'll take those as an accurate record. So matters arising from that board meeting are on pages 18 and 19, and I think all of those have been completed, given that they were a couple of months old now, because we then had the board meeting of the Foundation Group on the 5th of November. Are there any points of accuracy on those? Could you again raise a digital hand for me, please? Okay, again, I can't see a digital hand raised, so I'll take those as an accurate record. And then we have no action points arising on those, so that makes life a little bit easier for everyone else in this busy time. We've had a busy morning already in terms of our board workshop. We've been talking a lot about our role as lead provider and the important work we have working with our primary care colleagues, not just across South Warwickshire, but Warwickshire generally. And we're excited about those developments and the opportunities they present, I think, for all of the healthcare system across Warwickshire to work more closely together and more effectively for our citizens. And we'll be discussing that a bit more in our confidential section. We then had an important discussion about equality, diversity and inclusion within the board workshop. And I'd just like to reiterate once again that as a board and as organisations, we celebrate inclusion and the benefits of diversity for different perspectives and adding value to the services we offer and to the people, the citizens we serve. So that was a good discussion, some real things to celebrate there. But with the challenges in society, we all recognise that that's a journey that we need to continue to keep an eye on and support our colleagues and the work that they do. We also had a presentation on advanced nurse practitioners and advanced clinicians, as well as physician associates. And the makeup of our workforce over the next few years is going to be absolutely critical as we look at the increased demand that we have and the way of best achieving high quality service by using those new and developing ways of training staff and developing staff. So a good session on that. So a broad ranging workshop already. So without further ado, we'll move on to the Acting Chief Executive's report. Adam, how are you seeing things, please?
Thank you, Russell. So I will take the report as read, but I do want to pull out a few highlights from it and potentially from each section in there. So if I start with the medium-term planning framework, the medium-term planning framework was published last month, and I think this is great news for us and the NHS as an organisation, because it's earlier than usual for planning guidance, and it's a longer term framework than we've seen recently, and that allows us to plan in a less reactive way and gives us a bit more time to do the work. Having said that, the first stage of the plan we need to submit has really quite tight deadlines, and our teams, particularly led by Ravi and Sophie and Harkamel, are really focused on their elements at the moment for the first submission, which we have to do next week. We had our first meeting with the ICB regarding it yesterday, and we had a bit of discussion on some of the financial and performance elements of it in our board workshop this morning, as Russell said. I think the report is quite ambitious in terms of some of the performance improvements expected over the next 3 years, but absolutely rightly so. And I think in both of our organisations, we're on a good track to delivering those. In terms of performance more generally in the trusts, the NHS oversight framework for Q2 is going to be published soon. We should know the outcomes and gradings and league tables and so forth over the next couple of weeks. So there's nothing we can share publicly about that yet. I think other than to say we know we've made some really significant performance improvements at George Eliot since the last NOF segmentation was released for Q1. So we expect that to see that reflected in the results this time, and we also believe we've maintained good performance at SWFT. So look out for that. I hope it will be a good news story for us, given all of the work that's gone in by our executives and by our teams. In the last few weeks, we've also done some real focused work on some of the elements of patient experience at George Eliot that have been challenging. So, for example, we've eliminated corridor care in the emergency department there, something none of us wanted, and a real challenge, we know, for patient experience. So well done for the teams there addressing some of that. That all said, the winter period has definitely begun now. We have been extremely busy in both of our trusts over the last week or so. We've also started to see this effect of some of the winter viruses. So flu is particularly prevalent across the NHS at the moment, and I think we're seeing that particularly at SWFT at the moment. I said it last month, but I'll say it again. The vaccinations are showing a good barrier against getting seriously ill with flu. So I would commend that to members of the public and indeed our staff to have the flu vaccine. Both trusts have vaccination programs for staff and are doing well on the uptake at the moment, but absolutely you don't want flu this winter, so please do get a jab if you're able to. In terms of winter more generally, we've got really robust plans in place led by Harkamel as our coup. We've opened extra capacity. We've put extra measures in, particular emphasis this year on keeping people well in the community in line with the 10-year plan. But we are expecting winter to be incredibly tough and are managing that very proactively. In terms of some other changes in our organisation, last time I updated here, I talked about the new single executive leadership team that was put in place from October. Over the last couple of months, we focused on the next steps of that plan and really recognising that we have to have resilient operational services for winter. So we've put in place a new divisional structure across George Eliot that mirrors the structure we've put in and piloted over the last few months at SWFT. That's a structure that enables really rapid sharing of best practice between the two trusts. It enables us to put some more cross-cover arrangements in when we need to. And most importantly, it aligns our services to clinical pathways. So our unplanned services are managed together and our planned services are managed together. And that really helps to unblock any issues in the transition between elements of our services. So early days with that at the moment, but what we can already see is some of that sharing of best practice is having a really positive impact on both trusts. It's a two-way sharing. So we will keep monitoring that over the winter and review in the new year and make any further changes we require next financial year. A few other points to note from the report. I want to mention the CQC inspection that happened in SWFT in late October. CQC performed that unannounced inspection, visiting our urgent and emergency care services, our children and young people's services, and our both acute and community end of life services. The inspection actually could coincide with some of our busiest ever days in the emergency department. Certainly that first day of the inspection was our busiest ever day in ED, which is clearly challenging when staff are managing that level of pressure. But I also think sometimes when we're under pressure is when we perform the best. And it certainly gave the CQC the opportunity to see us managing some of those really difficult site pressures. We haven't had a draft report yet. I think we probably won't get one until the new year with the Christmas break now. We've provided the data we needed, that we provided some more over the last week. That's always the stage that follows an unannounced inspection. Having said all that, the feedback we received on the days, both from the inspectors on site and from our own staff, was positive, and our staff were really supported and encouraged to share some of the best practice and challenges that they have day to day. And the feedback, the immediate feedback from the CQC didn't raise any particularly serious concerns. So again, we're hoping for a positive result there, and we'll feed back more to board when we've got it. We are in the heat of our electronic patient records implementation now, as I've reported here previously, and we are following the work that UHCW have done over the last couple of years to implement the Oracle healthcare system. We thank them for their support that they're providing to the programme. We're currently in an important phase. It's called localisation. So that's the bit when we make sure the system is right for our own staff needs and for our own patients. And that is challenging. EPR programs are always really challenging. Getting it right is difficult. We don't plan to go live until towards the end of next year. And the program is being led by Robin, our Chief Digital Officer. It will be a big focus for our staff over the next year, though, and a big challenge and transformation in terms of the way we work. So I want to make sure board members and the public are aware we're doing that. Tremendous patient benefits in terms of sharing across the system and in terms of the way we can transform our services when we get it right. The report also notes the work we've done in Ellen Badger. I've reported Ellen Badger as opening over the summer here before. We're now running outpatient activity there. GPs are soon to move in. We're really, really proud of the wellbeing facilities in the building, which are designed to be used adaptively with the local community and local voluntary sector partners. And we've got some really good stuff going on there now. GPs, as I say, move in soon. We're also really delighted that we've been able to start a 6-month medical day case unit pilot, which is providing for day procedures to take place at Ellen Badger, so those patients will not have to travel to Warwick from the local community for those procedures. So great stuff there, and we're really seeing that exciting ambition we had for Ellen Badger, which aligned with the 10-year plan. Couple of other things to note. Board to Ward programme particularly focused on allied health professionals over the last month, and aligned with Allied Health Professionals Week in October. Sometimes our allied health professionals don't get the profile they deserve in the organisation, but they're a really important part of our clinical teams doing a great job. Board members visited both our acute and community services and saw some exemplary examples of the MDT work and going on there and the compassionate care that those teams are providing. So well done to our AHPs, and thanks to our board members who took part in that visit. Finally, I want to mention the George Eliot Emergency Department Resus expansion. So in October, we opened our £3.5 million new resus area in George Eliot, which doubled the number resus beds. It's a bigger area, state-of-the-art equipment, and a much-needed development for George Eliot. It was opened by our urgent and emergency care receptionist, Diane Warren. So thanks to Diane, and really showed the collaboration, I think, that had gone on in the development of the resus area between all of the clinical specialties, admin staff, management staff working at George Eliot. We have seen a significant increase in UEC demand at George Eliot, about 7%, and the new resus area is already supporting that. But more importantly, we've had really good feedback from our staff about the improved layout and how the working conditions really help them do their job and support our patients. So thank you to the UEC team there. And indeed, thank you to the UEC teams at both trusts, who particularly at the moment are dealing with some really significant pressures as winter starts to bite. I'll leave it there. Thank you, Russell.
Thank you, Adam. Very comprehensive. The only thing I guess I would add is the new ICB on the clustered Hereford and Worcester and Coventry and Warwickshire cluster are coming together. And I have to say, I'm absolutely delighted with the people that are at that senior level now in our ICB. I think we will have extremely fruitful and sensible discussions and work going on with them. Any questions or perspectives to Adam? We'll obviously come back to the IPR a bit later. Okay, thank you, Adam, and thank you for your leadership. We'll move on then to the mid-year review of the annual trust objectives. Back with you, Adam.
Thank you. I'll largely take this as read. Obviously, we're halfway through the year. This reviews our position with the objectives we set for both trusts at the start of the year. Those objectives are shown for George Eliot in Appendix 1 and SWFT in Appendix 2. The list for George Eliot is fairly long, but there's some good progress being made. Most are on track, some are complete. Some are reporting amber, but with no major concerns at the moment. Again, SWFT objectives largely on track with a couple of ambers. There's nothing I'm unduly concerned about for either trust, but I would just note that both trusts are on their objectives related to the electronic patient record system that I mentioned earlier are reporting as amber, and that reflects the challenging nature of that programme. In terms of objectives for next year, we've revised our approach slightly, and we'll have a consistent format for objectives. We've already engaged with our governors, with staff members and others in the development of those. We'll have some common objectives for both trusts, and then we'll have some individual objectives for the two trusts. And we'll have a board session in January, actually, a workshop session to talk through some of that in more detail. I'm happy to take any questions.
Thank you very much, Adam. Any questions or perspectives on the progress on the annual trust objectives? Robert?
Just a quick one for me, and I probably should know the answer to this one, but so we've got our 4 big moves, we've got 12 objectives that fall under that, and then we've got 6 thematic pillars, and then we've got the actual strategic activity under those pillars. I presume there isn't sort of a straight read across from digital to EPR and research to something else. That is there a mix? Do the pillars run throughout all of those sub? Does that make sense? That question.
Yeah, so the pillars are effectively enablers for all of the work we're doing. So you could read them as cross-cutting. The George Eliot ones have been done slightly. I think you're referring to the SWFT ones, Robert. The George Eliot ones have been done slightly differently, and that I agree is a little bit confusing. But we'll make that consistent for next year.
Okay, super. Thank you, Robert. If there are no other hands raised, and I can't see any, we'll therefore move on to quality and the report on safe nursing, midwifery and AHP staffing, including the acuity and establishment review. Fiona, over to you.
Yeah, thank you, Chair. So the staffing report, as you can see, lengthy report. Apologies for that. We will cut it down in future boards. It's just an amalgamation of the 2 reports that have been going to the 2 different boards. Overall, I can give you assurance that both organisations have really clear oversight of their staffing on a day-to-day basis, shift-to-shift basis, but also the divisions and directorates have robust plans to reduce bank and agency, fill vacancies, and manage the safe staffing across all these professions. There are risks identified within the paper, individual professional groups around recruitment and vacancy position, but the overriding, and I'm sure Ashley will bring this up through her report, the overriding theme really is the sickness that's driving the bank spend across majority of areas, and creating some gaps. I think we manage it, but it's a financial risk more than a safety risk. So lots of information in there, but that's a summary. Because the acuity review data has been included, it's probably a bit too soon for the board to have seen that. So again, I apologise. It's a high level summary, but it is only George Eliot. I will align the acuity review process across George Eliot and SWFT in the as of next year. Both organisations have historically been doing the acuity review twice a year, but this probably should have had a discussion at People Board first, and then going into planning and budget setting. So there's a lot of detail there. I'm happy to take questions outside of here, but that would be the governance I would apply going forward.
Thank you, Fiona. Questions or perspectives on the safe staffing review? Paul Caitner.
Thanks, Chair. Just an observation, I think, with stated ambition for this year, going into next year, of zero agency spend, I assume there's an opportunity for us to move people that currently work on agency within our trust. I know we're trying to limit that anyway, to recruit them substantially. I mean, there's going to be a number of individuals who are working in agency and have chosen that way, who, in theory at least, are going to be totally unemployed within the not too distant future. So I'm guessing that should be a target audience for us, Fiona, to help with our vacancies.
Paul, forgive me, I'm not sure of the work that's already been done on that in George Eliot, but certainly at SWFT we have I'm just choosing my words carefully. We have had individual conversations with agency staff that have worked here consistently over several months, if not years, and are doing that piece of work about encouraging them to apply for our bank. In George Eliot, it's slightly different. They have the NHSP contract, don't they? And we do need to align that arrangement really in terms of how we manage our temporary workforce, and that is planned for next year.
I think, Paul, there's a need to be quite forensic on this. I recall one of my night shift visits a while ago where I came across an agency nurse who travelled up from London to do the night shift with us on a regular basis. Absolute wonderful woman with lots of experience. So I think there is a need to be quite forensic. She was a wonderful example of an agency nurse. I'm sure there are other examples where agency nurses don't have that level of commitment. So I think there is a need to be forensic and not throw the proverbial baby out with the bathwater. Oliver?
Thanks, Russell, and thanks, Fiona. Really good report and really positive to see. My only questions, small question, just looking at the graphs from SWFT and George Eliot nurse vacancies, and everything seems to be going in the right direction except for support workers at George Eliot, which have been going up since April. I just wonder if there's some underlying reason behind that.
So support workers are a more transient workforce, Oliver. I don't know the specifics. I can go away and find out. But certainly, in my experience at SWFT and in other organisations, support workers do have a higher level of turnover. They often take a support worker role before they go to do their registration as experience in healthcare ahead of going into university to apply for either medical or nursing registration, or they take on roles during the summer as a student. So they are more transient. I think I I think the pay is an issue. You know the narrative there, that you can be paid as much in Sainsbury's as you can in a very difficult job. So I think that piece of work is going ahead nationally on recognising the challenges of a support worker role, and we do invest quite a lot in them in terms of training and support and development. Again, my knowledge is greater at SWFT, but I'm positive that the learning and development team are very good at George Eliot. I'm just not sure of the sort of detail around the support worker role. Yeah, I would say that in my experience more globally, that is some of the themes that come out, but I can find out the details at George Eliot. Yeah.
Thank you. Thanks, Fiona. I'm sure those are the factors that you mentioned. Christina, this is just a board meeting, so we don't. This is just for the board questions and perspectives at this stage. If you want to ask a question at the end, you're very welcome. And Ashi?
Thank you, Russell. Yeah, just I guess to support Fiona's narrative as well, and we can absolutely find out the reasons for people leaving from those support worker roles. But just to add in that George Eliot in particular hasn't finalised the arrangements for the transition of Band 2 to 3, so that possibly could be a reason, but also potentially also will be a good incentive. And as Fiona said, we do then offer training and development and formal qualifications for those individuals in the Band 3 support worker roles as well, so we might see a difference when we get to the end of that piece of work, which we are working with support worker colleagues as well as trade unions around.
Just two things I would add on that particular issue, just to remind support workers who may consider working in other well-known retailers as an example, the pension they will get at the NHS is probably 5 times more generous than the pension that they would get working for a retailer. I also just want to make a point about inadequate staffing incidents, and I'm looking particularly at page 68 of 562. I am very conscious that if you are on a ward or in an emergency department and you're having to wait and there's sickness which has caused a level of inadequate staffing for a particular time, you can feel very frustrated. I totally understand that frustration. However, it is never acceptable to be abusive in any form, whether verbally or physically, to any members of staff. They are doing their absolute best in the circumstances in which they find themselves to provide the best, safest care for you. So members of the public, we have our part to play into continuing to be kind and civil, despite the demands and exhaustion that the frontline teams experience. But members of the public and families, you equally have a responsibility to be polite and kind towards my teams. We'll move on, thank you, to the perinatal quality and safety report, which I've got Linda Wall down as this, but Lorraine, I think it's you today, isn't it?
So we're going to do a double act if that's okay, because I'm only just back, but I think Fiona wants her to speak first and then I'll take the paper.
Okay.
Yeah, again, board, thank you for receiving such a lengthy report. It is 2 reports from 2 different organisations still at the moment, but now that Lorraine is back, we will look at reducing the template and also mirroring the dashboard, so that comparisons, as we have in the integrated dashboard, the comparisons can be made with the same KPI. So that's the next steps, but I'll hand over to Lorraine and Lynn for the detail.
Thank you, Fiona. And yeah, as you'll see, that George Eliot is a monthly report and SWFT is a quarterly, but as Fiona said, they will be aligned to go quarterly from the next board meeting. So this is data for George Eliot for October 25. There were no serious incidents declared. There were no stillbirths or neonatal deaths in month, and the rolling rate across the 12 months remains below the national average. The midwife to birth ratio was 1 to 25, and all women received 1-to-1 care in labour. Our prompt training, which is our multidisciplinary training, remains at 96%. There was one published perinatal mortality review tool in October 25. All that learning has been shared, but the report just highlights there was some learning identified around improvements in sharing information and accessibility of services, which the team are working on. There were no open MNSI cases, and there was no external concerns or regulations received. MIS CNST Year 7, obviously this is October's data, but it did complete at the end of November. We're still working through our compliance, and the report just outlined some of the areas that we needed to make sure that we'd got robust action plans to ensure compliance going forward. And obviously we'll report in the confidential board in February of our compliance at that stage. Our Saving Babies Life compliance improved again in month in October to 97% from 94%, so on doing well and on track. The paper, obviously it's a very lengthy paper, and again we will look at that, but some of these concerns just for the trust to be aware of is around some work we're doing around theatre staffing with at George Eliot with the AFP recommendations, and making sure the midwifery workforce in emergency scenarios will have the competency if they needed to go into theatre to scrub. We're looking at our open incidents and making sure we've got governance processes to reduce those, and making sure that our guidelines are being reviewed in a timely manner. We're also just highlighting that the 21% uplift for training doesn't always meet the requirements for maternity, and obviously there's some variation across our trusts within the organisations across our patch. And just to say that our obviously, as you know, and it's always been something I've talked about, our maternity lifts remain our vulnerability. Obviously we've had one lift refurbished, and the second one is being refurbished as we speak. Our BCP plans are in place. We've got actions to mitigate, and we're hopeful that the work will be completed in December. Those are the main highlights out of a big report, but I'm happy to take any questions.
Thank you, Lorraine. Lynn, is there anything you'd like to add?
Yeah, so if it's okay, I'm just going to do the highlights report for SWFT because it is Q2 that I'm presenting, and then we should be hopefully on track next month, as Fiona has said. So the SWFT report reflects our current challenges, as you know, so I'll just go over a few. So successes, we transferred over the management of obstetric theatres. We've been trying to do this for a really long time. So the elective division now manages our obstetric theatres. So the process was completed in the quarter. We've had some small challenges, but actually it's working really well. So hopefully moving to a business as usual model. We had a really successful visit from the local maternity and neonatal system. They attended our insight peer review alongside the maternity and neonatal voices, and that report will be included in the next board report. They did provide, though, excellent feedback on our culture at SWFT and the progress that we are making towards the Maternity National Single Delivery Plan, which was really lovely. Current challenges are around the obstetric cover at registrar level. High acuity really means challenges for our obstetric staffing, but we have been successful in recruiting 3 further registrars within this quarter, so that should really support our safe staffing. Also, one of our challenges is not proceeding with the capital refurbishment of both our obstetric theatres at Warwick Hospital. They've been in situ since 1984 and remain on our maternity risk register. The service was also worried around the introduction of the new electronic patient record system. This brought to life several risks for us that we identified. We worked with Innovate really closely. So, and due to the lack of mitigation available, we are temporarily just escaping from the programme, but we're still working really closely with our Oracle Health colleagues and Innovate colleagues on a smooth interface between our badger system and the system that will be across the trust. Maternity incentive scheme compliance was at risk in this quarter, as you'll see in the report. So we continue to do lots of hard work in the last couple of months to now support full compliance, which is good news. Health inequalities work remains ongoing. We're actually working really closely with George Eliot, with our maternity public health team around poverty proofing, and work continues to support our asylum seekers within our maternity population. And the public health team and the maternity neonatal voices partnership have just launched actually this week neurodiversity friendly kits to support our families while they're having their care with us, which is a really positive step. And then just to mention the medium to long-term risks to our service provision. So we commenced a capping in 2025, obviously this year, August, and we're waiting to see those effects. But due to obviously a lead time of how long you're pregnant for, we won't start to see that for another couple of months. We are really closely looking at the numbers and working out if there is any scope between our late transfers and our out of area ladies, and then we'll keep the board updated with that. Medical staffing position, long-term across obstetrics and paediatrics, also long-term risk, especially if we do continue on a trajectory to birth over 3,500 families per year. And currently, the national requirements for obstetric and paediatric staffing, we're hoping it will start changing, especially with the new bathroom requirements. Our key data and targets position is good. Staffing metrics show high sickness and vacancy in maternity support workers in Q2, but this has improved in the current quarter. Key training matrix also shows improvement in most areas apart from safeguarding, but there is a really good plan in place for that, and that is also improving within this quarter. The maternity incentive scheme, Saving Babies' Lives, shows in Q2 that it, as I said, needed work, but that has all now been completed for this quarter with 100% compliance in both, which is really good news. The NHS Midlands perinatal team had wrote to all of the trusts to ask about reviewing their fetal growth surveillance pathways and systems. This was in response to some regional concerns about plotting and accuracy of fetal growth. So we completed a gap analysis with George Eliot and have created a report so that you can understand what position that we're in at SWFT. And that's it. Happy to take any questions also.
Two very comprehensive updates. Thank you very much, Lorraine and Lynn. Any questions or perspectives on those updates? Ashi?
Thank you both. Yeah, really comprehensive reports. I was just interested if there was any data that we have or any insights, particularly around the health inequalities that you talked about. And I'm thinking specifically for those kind of mothers, babies from ethnic minorities and their experience of care, or are they at detriment? And I couldn't quite pull that out from the reports. I didn't know whether there was insight into that.
Lorraine?
Yeah, absolutely. So as part of when we do all our reviews of any incidents, risk assessments, perinatal review mortality tool, ethnicities and all actually the 10 special characteristics are now included in that. So that will be probably outlined more in the detailed report. That would be for those, but every incident or case that we review, we do look at particular ethnicity, health inequalities, the impact that will have on that, as do that when they do the M&SI reports, they do a section on whether any health inequalities had an impact on any poor outcomes. So it is part of that ongoing process, but obviously we can give you further information, but it will be in one of those specific reports.
Thanks, Lorraine. Thanks, Ashi. And Fiona, then.
Yeah, I just wanted to add, Lynn referenced the insights visit from the ICB LM&S into SWFT last month. We had that this week at George Eliot, and again, it was equally positive. And just linking that, Ashi, into your comment, the theme across both of those regulatory visits was they're called supportive visits, was inclusivity, and they were very assured that we do very well across both organisations. But actually, it would be helpful if you spoke to the midwifery consultant midwives, because they both are focused on supporting continuity of care for our most at-risk women, which are those that you're talking about. Thank you.
Just a couple of things from me, particularly for members of the public. I often say at the board meetings, in my view, as a trust, we have three ultimate priorities. The first is to bring life safely into the world. The second is to help life leave this world with dignity. And the third is when you've got a medical emergency, that we are able to respond quickly and rapidly to address that for you. And that's why the midwifery work that we do is so important, in my opinion. And that takes me to the issue of the cap, Linda, that you referred to. I'm sure there are many expectant mums and parents who are disappointed if they're finding it difficult, if they're out of area, to come to Warwick. And the reason we are adopting this cab is for that first reason, to bring life safely into the world. We don't want to get so busy that we put any baby or mum at risk, and therefore we do need to manage demand. We are the victim, particularly at Warwick, of our own reputation of people wanting to come from out of county to give birth in Warwick. And so Lynn, Lorraine, all of the team at Warwick in particular, thanks. But I know there are some difficult conversations going on around the implementation of that cap. We'll move on then to the Swift and George Eliot Health and Wellbeing Biannual Report. Need to watch the time a little bit, team. Ashi?
Yeah, thank you, Russell. So if I can, and apologies to the board, I would, on reflection, having kind of spoken to colleagues and more recent updates, like to change the assurance. So I don't think I can today give full assurance to the board in terms of the health and wellbeing agenda. And would like to drop that down to significant assurance. And I guess the reasons and the rationale for that, and you can see within the report. So both organisations already working jointly around health and wellbeing offer a huge range of support to our staff, which I think is absolutely making a difference. However, we are still seeing those very high levels of sickness and absence across both organisations above our own target and above certainly the national KPI, which is currently 5.1%. And then our other area for real focus, which we are working on, is around our occupational health provision. And so working with both our current provider and new provider in terms of implementing a new service. So that's the rationale. So apologies for that kind of late amendment, but I don't feel comfortable now giving that full assurance. But in terms of the remainder of the report, and I will take it as read, you can see our areas of focus, certainly around the health and wellbeing support and the hubs we want to create on site for staff. So it's much more around visibility, immediate access to support. And then our other areas, because we know that our highest levels of sickness absence are related to mental health reasons, stress, anxiety, but also musculoskeletal. So those are the priorities we've been working on and continue to work on. But I'll perhaps pause there, Russell, for any questions or reflections.
That's great. Thank you, Ashi. Any questions or perspectives on the health and wellbeing biannual report and Ashi's comments there? Ollie?
Yeah, thank you. I think just to firstly comment that the speed of the OH procurement's really good, and it's good to see there are other things we're putting in place to address that high sickness and absence. My question is, even once we've got the various new policies and posts that we're putting in to try and tackle this, is that enough? Will that be enough?
Yeah, thanks, Ollie. And certainly we've had, board colleagues will be aware of other conversations we've had around more immediate support and some ideas there in terms of what we can do immediately. I'm confident in terms of our longer term plans, but actually it's more the here and now, and particularly the support we're giving to our managers who are then managing their staff through sickness, whether that's short term or longer term, the skills they need, but also the capacity. And I think that's something immediately we're trying to address in the HR team around refocusing and really targeting those areas that might need more support than other areas where there's a lower sickness absence rate, or for example in ED areas when we know staff are really dealing with challenging situations. Let's focus our support there.
I'm sure we've got to invest to save in this type of area, Ashi. And Umar, then we'll move on.
Yeah, thank you, Ashi. Some really great work. Just to kind of check, where we kind of checking that the progress is happening on this, is that at the people board, in terms of keeping an eye on the initiatives, and I call it the so what factor. Is it working? Is our return on investment coming, etc.? So I just wanted to check that that's where it's happening.
Yeah, a number of places email. So from George Eliot, there is a people board, and we also report through to the quality committee as well. And then over at Swift, there's different forums, also trust management board. We have a focus particularly around sickness through the Excel in Everything. Is that the correct terminology? Yes, that's Fiona chair. So different forums, but moving forward, we will be having a joint people board across both organisations, and we'll report there.
Yeah, just to put this into some context for members of the public, our sickness level, for example, at SWFT is running over 6%. If we were running at 4%, which is the NHS target, we would save £2 million a year. This is not a trivial issue. This is a real financial issue, as well as a strain issue on those colleagues who have to pick up the slack when other colleagues are off unwell. So this point I made earlier about us needing to invest to save, I'm sure is true. There's a lot of money to be saved here, and it's better for everyone if staff that we employ are at work and to help them get back to work. We'll move on then to the SWFT Patient Forum 6th monthly update report. Look forward to the George Eliot one as well in the future, Fiona, but over to you.
Yeah, you preempted what I was going to say. So yes, I will make sure that this is across both organisations. I have met with the Patient Forum at George Eliot, and wow, they blew me away with their enthusiasm. So I'm sure they would like to write a report in the future, as Chris does here. The other thing that I would like to have a conversation with them is about actually including some of their feedback about our care, because that is their role. And that would just allow us more assurance or more triangulation of evidence around the care that we're providing from an independent body, which is the Patient Forum. So you can see that Chris has written her membership of different groups and committees across SWFT, and the active work that her and her members do. And I just really want to take it as read, but say a great big thank you to the Patient Forum for supporting our work in improving patient experience.
Thank you, Fiona. We've got Natalie in the call. One of the things, Fiona, I'd quite like you to think about, which will be after my tenure, is at Worcestershire, I have the chair of the Patient Forum actually present their own report for 5 minutes or so. And it really allows that Patient Forum to feel that their voice is heard directly. So can I just ask you to take that as well as a thought? Any questions on the SWFT Patient Forum report? Okay, so we'll then just move on to the 10-point plan to improve resident doctors' working lives.
Sorry, Russell, could I just ask a quick question?
Sorry, Jackie, I didn't see your hand go up.
It's okay. Chris had mentioned that they're having difficulty recruiting, and I just wondered if there's anything more we could do to support that.
Having spoken to Chris, I think one of the practical issues, Jackie, is how difficult it is to, Julia, like I said, if you want to pop something in the chat box, you're very welcome, but it's still a board-only discussion, is the real problems they have of getting their DBS and other checks through, which takes an inordinate amount of time. Fiona, anything you want to add?
Yeah, we have fed this back to the recruitment team, Ashley, but if it's new to you, I apologise. They find it quite clunky, and I think it's sometimes the IT interface, the track and the SWFT Learn, but it has also felt quite a lot of induction training for the role that they're doing. So there was a piece of work going on to review what is absolutely necessary for a Patient Forum member who isn't delivering care, but is participating in voluntary work, and so try and streamline. But that's the feedback, Jackie.
I know you're very busy, Fiona, on the shared leadership work, but it does seem that that's taking an inordinate amount of time to actually improve. Every time I speak to Chris, it's still on her irritation list. So if I can ask you to take that away.
Yeah.
And then we'll move on to the 10-point plan to improve resident doctors' working lives. Naj?
Thanks, Chair. So as the title suggests, this was introduced by NHSC in September. It's a 10-point plan, and it's to improve both working conditions, rotas, etc., as is in the paper attached, which I'll take as read. But if I've taken the liberty of inviting our two really excellent directors of medical education for SWFT and George Eliot, who are leading the respective works and doing a brilliant job of co-production. Here's the report, as you can see in the report. So if I may, I can just ask Andrea first for George Eliot and then Ratty for SWFT, just to give a very brief update on our progress against the NHS 10-point plan for resident doctors. So Andrea, do you want to go first, please?
Yeah, thanks, Naj. So I met with the Associate Dean for NHS England early in the week, and he wanted to commend both SWFT and George Eliot for where we're at with this, that both trusts are one of the best, highest scoring in the region. We're probably not far off really meeting the 95% compliance which we've been tasked with. At the last count we were 87%, but actually we've turned quite a few things green since then, so we probably have actually achieved the target. We're about to do another self-assessment that will go back to NHS England, and I'll liaise with Ratty about that at the time as well. Ratty, I don't know if you want to say anything.
Thanks, Andrea. I think, as you said, I think we did meet with the leads in the NHS England meeting recently, and I think, as you said, both SWFT and George Eliot are scoring quite highly on our self-assessment. And I got Martina with me, who is our peer resident. I think you got Michael, who is our peer resident. And what we are doing is we are going through what we have scored ourselves against, along with our peer residents, to make sure that we triangulate everything. So actually, as you said, I think at the moment we are close to 95%. There are aspects that we think we can work together to try and resolve. But overall, it looks like both the hospitals and both the trusts are working very closely with the residents to give them a good experience.
Thanks. Can I just quickly say that thank you to Martina and Michael. So one of the actions is that we have to appoint a resident doctor representative, and Martina and Michael have stepped up for that. So thank you to them as well for their sparing the time.
Yes,
Thanks,
you.
Chair.
Okay, super. Thank you, Andrew, and thank you, Ratty, for everything you're doing, and glad to see the progress we're making in this regard and the recognition we're receiving. Adam?
Yeah, thanks, Russell. I just wanted to emphasise the importance of this. We have another round of resident doctor strikes coming up in December. It's just been announced, 17th to 22nd. We obviously can't influence the national position on pay, but what we can do is make sure the working lives of our resident doctors are as positive, as supported as possible. So I think it's very important as a board we have assurance that this plan is being driven forward, and thanks to Andrea and Ratty and Naj for all the work they're doing on it.
Super, thank you. And Oliver, and then we'll move on.
Thank you, and it's great to see the progress that you guys have made. It's fantastic. So, huge congratulations for that. I guess my question is, what should we see as the outputs of it? So it's brilliant that it's been done, but should we see any that reflected in reduced sickness levels or anything like that we can measure the material impact of that?
Naj?
Yeah, so there probably various. I mean, one of the ones would be the GMC surveys that are conducted regularly, and that's very much down to trust level. So we'd love to see improved sort of feedback and in those surveys which come up. So that's definitely one metric that we'll be keeping an eye on. Andrew, or Ratty, was there anything else that you can think of? But yes, sickness levels, anything that improves their lives, and we'd expect to see some sort of parallel improvement in that. Ratty, you've got some?
Yeah, I mean, I agree with that. I think you're right in saying probably GMC survey and the NET survey that's ongoing at the moment will probably be an immediate reflection. But you're right, Oliver. I think in the longer term, I think we're hoping that, it's a sense of belonging, isn't it? That the residents actually feel this is their hospital and they actually come. Maybe we will see more reduction in patient safety incidents. We see a reduction in staff sickness. And I think, Martina just wants to add a word.
There are two actions being taken, really, one being the NHS England 10-point plan, and another one something that we're doing a bit more locally, which is the resident doctors engagement group, where, coming from the bottom almost up, we're trying to identify the issues that have been going on for a while, most of them, and see what would be the best solutions from the resident doctor's point of view, liaising then with the decision makers and saying what is feasible and what's not. By that, we can, of course, communicate to the resident doctors these are the issues that we can't address because it's coming from the NHS England, and that's where we're blocked. But actually, there's this group of issues that we can very much address on a local basis, improving the workforce and well-being, hopefully also impacting then sickness levels and satisfaction.
Yeah, I'm sure one of the things we can do for resident doctors is to make sure if they've gone through all their training that there's a job at the end of it. But that's beyond our pay scale. I think there might be some other questions popping into the chat box. If you want to stay on the line, Ratty and Andrew, just for a minute, that would be super. But otherwise, I'll move us on to the performance section and the integrated performance report and Adam's overview. Adam?
Thanks, Russell. I always worry slightly I steal my colleagues' thunder when I do this bit. So I'm going to be brief and give some headlines and then hand over to them. So I think first thing to say, and probably what I always start here with, is that it's been extremely challenging in terms of urgent care demand at both trusts. And we've seen unprecedented attendances over the last few months at both organisations. I think despite that, there's been some positive news regarding performance, and I think positive also in terms of our work to reduce waiting list referral to treatment times. So there's some good stories there you'll hear about. The demand itself is creating significant financial pressures. We knew this year was tight financially anyway, but the levels of demand we're seeing has meant that we have had to have extra capacity open. We've had to have additional staff rotated, and of course that all costs money, so is creating a pressure. In terms of the areas where we have our most focus at the moment, cancer performance is a big one at SWFT, and Harkamal's got some detailed slides to talk about that further. And at George Eliot, the issue of flow, so long waits in the department, length of stay, medically fit for discharge patients. And in our shared leadership work, those are two of the areas we're really focusing on. I think it's also important to note that while we've had challenges in the reporting period, there has been some significant progress. The cancer performance is the notable one, where there's been progress since the last report. In terms of workforce, I think we've got some really good stuff going on. We've already mentioned it, though. Sickness is our biggest challenge and an area that we are really driving our work on to address. I'll leave it there, Russell, and hand over to Naj and Fiona first.
That's super, thank you. So Naj and Fiona, over to you on quality and safety, please.
Thanks, Russell. I'll kick off with the mortality stats and data. So for SWFT, the SHIMI, which is in-hospital deaths within 30 days of discharge, is at 1, which is within the expected range, and that's been sustained for a good few years now, so it's really good work from the SWFT teams. However, when we look at RAMI, which is another way of looking at mortality data, there are 3 groups where we are outlying, and that's acute kidney injury, sepsis, and pneumonia. And the teams, the normal way we will do this is when we find an outlying condition, we go back to the clinical teams, we go back to coding, because usually within that we can sort of resolve what the issues are. So from the clinical team's point of view, they will review the notes. And for those 3 conditions, what they found was there is a case mix issue. So for example, AKI, quite a lot of patients on palliative care pathway. There's often a common theme about documentation issues, and there's always something about coding, and they found the same thing. So there'll be targeted actions for those 3 conditions. And one of the ones, again, which is a common action, is around the use of bundles, which is a validated method of improving care. So these are evidence-based interventions, which they have to be done in a time order, and they've been proven to improve patient outcomes. So those 3 conditions, we'll be going back to the clinical teams and asking them to, if they could introduce bundles. But there is also that coding element, which we're always working on as well. From the George Eliot point of view, the SHIMI then at George Eliot is 1.07. And the main, the significant outlying condition there is fracture neck ischemia, and I've reported at previous board meeting. There is ongoing work. We have set up a task and finish group to look at this specific condition, because whilst it's come up this time, both on SHIMI and the National Hip Fracture Database, it has happened a year or so ago. So it is a recurrent thing, a recurrent condition that seems to become an outlier periodically. On this occasion, as I said, we've set the task and finish group, which is multidisciplinary. So these are clinicians involved in every point of pathway of the fracture neck of femur patient to look at the key performance indicators, which the National Hip Fracture Database look at as well, and to see whether at each of those individual points there's any improvement that we can make. And whilst they're doing that work, we're also doing structured judgment reviews on every death in any patient that has been admitted with fracture neck of femur. What we found in those reviews, and this is early sort of report, is that, and it's probably not surprising, they are a very elderly cohort, so over the age of 88, and they've got significant comorbidities and frailty being one of them. The team are working up a report and will provide a full report to our Quality Governance Committee in common in December. But the other thing we've decided to do, because this is a recurrent issue, I'm in the process of inviting the British Orthopaedic Association to come and review the pathway. They're an independent organisation. They do this across the country. They'll go in and review pathways and, again, review notes and processes. So we'll get an independent sort of fresh pair of eyes from the outside, a professional group, and hopefully they will provide us with, you know, anything else that we need to be doing. Apart from that, the other really important function for both organisations is the medical examiner function. So we have medical examiners who act independently and will review all acute and community deaths. And they maintain 100% review records, which is great. They're able to review each of those patients that have died, as I say, which are non-coronal, don't need to be referred to the coroners. And from those cohort of patients that they review, they will then select if they think someone needs to be referred to a coroner who hasn't already been done. That will happen. And there's some data in the slides to give you those numbers. And sometimes they'll just ask for internal review. If they're not sure about the quality of care a patient's receive, they'll do an internal review request, and that's the structured judgment review. So those are our own sort of internal assurance processes, which are working really well in both organisations. So that's the mortality data.
Okay. Need to watch the time, team. Very comprehensive, Naj. Thank you. If we can come back to questions after we've heard from Fiona. Fiona?
Yeah, thank you, Chair. So the rest of the report from the quality section just compares and contrasts between the SWFT and George Eliot figures, particularly around incidence of falls, medication safety, infection prevention, and pressure ulcers. There are some notable differences, and the quality and safety teams in the background are doing that comparison to make sure that it is apples and apples that we're comparing rather than apples and pears. But then I think there are some quick wins in terms of improvement overall. Things that stand out are the pressure ulcers developing at George Eliot for a while. That is concerning me. It is higher than I would expect, and we need to do some quick improvement work on that. Just to remind people that you may be alarmed about the number of incidents happening and the spike in incidents, particularly at SWFT. Just to remind you that incident numbers is a good thing. I want incidents reporting. It's a good reporting culture. It's a good, safe culture. What is challenging, or what we wouldn't be wanting to see, is a high ratio of harm related to those incidents. So we encourage incidents, and we always have done. Again, I think the incident reporting at George Eliot is lower than I want it to be, and we've got some challenges between some teams there about understanding that safety culture. We have had a spike in incidents at SWFT recently. Some of that is related to the move over to in-phase in the last 12 months. We've done that, and we have seen a movement there. But the team in the background take out any duplications, any incidents that come on investigation aren't incidents really, and they have got a backlog of that. They've had sickness in the safety team, so I would expect some of that to come down, but it's a healthy reporting number. So overall, going forward, I'm hoping that I'll have more actions in here in terms of what we're doing to push both organisations to the best they possibly can from a patient safety point of view.
Okay, super. Thank you, Fiona. That's very comprehensive. David, your hand went up. Did you want to ask a question?
The only thing I was just questioning is I know the discrepancy between the shimmers of the two organisations. I know they're both within national sort of acceptable limits, but I just wonder whether there's anything we should be concerned about. I know we've had discussions in the past about the complexity of how shimmy is collected, and it's not easily understood, but it is one of the nationally accepted indicators, mortality indicators.
Yeah, I don't want to spend too much time down this rabbit warren, and I'd like it to be picked up by Quack. But Naj, any immediate perspective?
I think, yeah, so historically, I think there's always been a little bit of a difference, but I think the main sort of reassuring factor is that both are still within those accepted ranges. What we haven't got, what SWFT has got, is RAMI, but both organisations, David, will be moving to HEAD in the new year. So then we'll have not only shimmy, we'll have HEAD to do direct comparison. That'll be, I think, really useful. Thank you.
Thank you.
But David, as Chair of Quality Assurance, obviously I'd expect you to take any anxieties forward. Let's move on, team. We're running a bit behind now, and we've still got lots to cover. To Harkamel, and who drives, if you like, the engine room. Harkamel, how are you seeing the operational challenges, and in particular, what assurance can you give us about cancer at SWFT? So over to you, Harkamel.
Thank you. So a lot of what I was going to say has been said. So it has been really busy in terms of A&E pressures, which is probably not unsurprising, like for October. I have put in the report that our ambulance handover delays have improved slightly at George Eliot and increased at SWFT. I just kind of wanted to put into context the fact that even though we've increased by 12 at SWFT, that is still really, really good performance in terms of ambulance handover delays, and we have not taken our eye off the ball. So I just kind of wanted to provide that assurance. From a RTT perspective, our performance continues to improve, and we really do have a focus on reducing our 52-week breaches. The only thing I wanted to highlight is that we have been asked to offer mutual aid, and I think there's just that balance of, as a provider, how do we manage to help other providers as much as we can, whilst also meeting our trajectories and the performance that we say we're going to meet. Just in the interest of time, I won't go through all the details of the report, but as you say, cancer is the area I wanted to pick up. So both at George Eliot and at SWFT, 62-day cancer performance is below target. And we can see in the report, I've included some slides on the 28-day and the 62-day standard, and the 28-day is improving at George Eliot, and the 28-day and the 62-day at SWFT remains challenged. So just to provide the board with some assurance, I've spoken in other forums around like what's driven some of this performance, and I've been talking for quite some time around my concern around the increase in cancer referrals. So June and July this year, for example, were our highest levels of referrals that we've ever had. If you then break that down by tumour site, skin has been particularly challenged. So our dermatology pathways have seen exceptional levels of demand, and that has been further compounded by other hospitals in the area closing services and small numbers, but still patients coming to South Warwickshire instead. So just for as an example, we saw 110 more patients in July 2025 for skin compared to last year. We haven't increased our workforce, we haven't increased anything else. And when you think all of these patients need to be seen, they might need a biopsy, it's quite a significant volume. We also had consultant sickness, so that did drive some of the position in terms of like we lost quite a lot of capacity at the same time that our referrals were increasing, and a number of actions have been put into place to try and mitigate this. So we are now doing teledermatology with our primary care partners, and I think we're a bit late to the party with that, but we are doing that now and working with our ICB colleagues to try and understand this demand and see if there is a better way to be treating some of it. We've also brought in insourcing, so it's really important, I think, for our board members to understand that we've brought in an external company who have helped us bring down those waits for that first appointment and helping churn these patients through their pathway. And we will keep the insourcing company on until March. By way of assurance for where our performance stands now, I said before on this call that we are in a tiering for cancer performance, so that means additional scrutiny from NHS England. As part of that, we submitted a trajectory, and I'm really pleased to say that we've kept in line with what we said that we would do. And the October early position does show signs of recovery. So it doesn't, we haven't formally submitted that yet, but just to say that the performance of both the 62-day and the 28-day performance has improved for us, and our trajectory for November, I'm expecting that to demonstrate that we are very slightly ahead of trajectory. But it's just to say that cancer is a real concern of ours for both George Eliot and Swift, but a significant worry for Swift. But we do have a plan, and so I'm assuring you that those plans are in place, and I will bring back to future board meetings if we do fall off plan for any other reason.
No, fantastic. Thank you, Harkamel. That's assuring in terms of the actions we're taking on cancer, but we do need system partner support to deliver the level of service that our citizens should rightly expect. Any questions or perspectives to Harkamel? Just for members of the public, I want to put into some context how busy our UEC have been. On one Monday, Adam referred to it earlier, CQC arrived in the evening. We saw, I think the number was 393 people attend. That was almost as many as UHCW saw on that day, and their emergency department is about 2 or 3 times larger than ours. But in terms of ambulance handovers in November, Warwick was the best in terms of ambulance handovers in the whole of the Midlands. So despite a phenomenal level of busyness, the emergency department at Warwick is doing, in my view, an absolutely extraordinary job. And over at George Eliot, I'm absolutely delighted, we've touched on it a few times, that the corridor care, which had unfortunately become part of the normalisation of way things were being done, we haven't had any corridor care in the last 3 weeks of the shared leadership. So really well done, the emergency departments across both locations. Questions and perspectives, David Spraggart?
Yeah, I was just going to ask Harkamel if she could make sure that I get as quality chair updated on the trajectory on the cancer performance, because clearly the Swift one, yeah, the trajectory is very definitely in the wrong direction, isn't it? And you're hopefully going to tell me that it's going to bump around the other way, but I'd like to see it on, for real.
Yeah, of course.
And so just going back, Fiona's popped into the chat box for those of us who can't see it, that same week there were 350 attendances at George Eliot. That there's something unfair, in my opinion, about the way the system loads up Swift in particular and George Eliot, because they know we're good at ambulance handovers and continually send people to us. I think I'm correct in saying that earlier on this week, we were taking transfers from other parts of Coventry and Warwickshire. When I say we, I mean George Eliot and Swift. When those other parts of Coventry and Warwickshire didn't have any ambulance delays, they were still sending them to us, even though we did have some handover delays. So that's a real disappointment. And our system partners, and I'm sure our ICB and your ICB colleagues will be helping us in this regard, really do need to recognise the unfairness. Just because we're good at getting people off of an ambulance, don't send more and more work our way, rather than challenge organisations who are less good at getting people off the ambulance. We'll move on. Ashi, on the workforce and people side, what would you like to pull out?
Thank you. So I think overall, actually, a really strong performance for both organisations, and you can see the detail within the report. Excuse me. Both organisations under the KPI in terms of recruitment and time to hire, which is really positive in terms of getting our staff and potential candidates into post. Low turnover rates as well for both organisations, again under our KPI target. And we have quite strong vacancy control measures in place also in line with our kind of workforce planning and workforce trajectories and the requirement to reduce workforce in some areas. So both organisations do have strong controls, and we now have a joint executive vacancy panel in place also. And then also generally from an appraisal and statutory and mandatory training perspective, both organisations are doing well in terms of appraising their staff and also training and supporting them, particularly around the mandatory training. There are some areas where we need to improve based on the actual learning compliance. So for example, Oliver McGowan is lower than where we want to be. So, and also thank you to both organisations and the staff who have completed their staff survey, and we'll be able to share those results once the embargo is lifted in future months back to public board. The area, however, where we have talked about it in a lot of detail today and over the past months is around wellbeing and in particular sickness absence. And sickness absence for both organisations, again, is above our KPI of 4% and has been for some time. We have included some national benchmarking also, which I think is really helpful to see where both Swift and George Eliot sit in relation to our partners in the foundation group, but also generally across. And you can see actually generally across we have a much higher rate of sickness. So in England, that is at 5.1%, but that's still below both organisations' current sickness percentage. So we do know there is work to be done. Also nationally, you're seeing that the highest reason for people being off sick is those kind of stress, anxiety and mental health issues, which again, both organisations is our top reason for people being off sick. And again, where we need to strengthen some of our support. And then similarly, issues around musculoskeletal, which again is our issue in both organisations. So I think that kind of puts in context also the challenges nationally that the NHS workforce are facing and experiencing. And therefore we're not different in that respect. However, our sickness is much higher. So generally, I would say actually a really strong performance in terms of our staff and their experience and where they are. The area we absolutely need to focus on though is wellbeing and sickness.
Thank you, Ash. And like you said, we had some good discussions on innovative ideas to try and help going forwards. Questions and perspectives to Ashi? Yeah, we've got to get that sickness down. Paul, and then we'll move on.
Yeah, just emphasising that point. If we look at the graph trends, that they are still going up. I mean, so if you look over the last 18 months, there's a steady rise, and there's been no obvious depreciation in that. I mean, obviously you get peaks and troughs, but actually the underlying data is saying it's going up slowly but surely. When do you think we're going to start to see a downturn in that, actually, given all the investment and initiatives that we have? I mean, are you getting some feedback from the front line that's suggesting that the tanker's turning, so to speak?
Yeah, and what I'm very conscious of, Paul, is we are now in winter, and certainly, and both organisations actually are performing well, certainly around flu vaccinations. But there is something in terms of this quarter that we're in and early in the new year around. We expect to see a high rate of sickness because of where we are from a seasonal perspective. Our short-term sickness, though, I think is an area where we'll start to see the drop as we have tighter controls. With both organisations have reviewed and implemented now a new sickness policy and as I talked about earlier, some greater focus support to our managers in particular areas. So I think short-term sickness is one area where we definitely can make and should be making a difference. And we do quite well actually in terms of supporting people from the long-term sickness perspective, but that I think will be more of a gradual decline. So if I'm being realistic, I don't think we'll see that real downturn until the new year and coming out of the winter period.
Yeah, I think it's definitely got the profile I'd wanted to have in all the discussions I'm in F&Bs and FRBs. So we look forward to real progress. We're running quite a bit behind time now, guys. So Ravi, this is turning out to be a very difficult year financially. Again, public recognition and appreciation for you stepping up into the role of interim Chief Finance Officer. But Ravi, what do you want to pull out?
Thanks, Chair. So whilst we've seen a small reduction in our run rates in month 7, the year-to-date reported position for SWFT is a 3.5 million deficit against our 1.1 million deficit plan. And for George Eliot, a deficit of 7.95 million versus a 6.9 million deficit plan. As you'll be aware, SWFT have been running at an underlying deficit of around 2 million a month, and the position has been achieved by releasing a fair amount of non-recurrent deferred income. This is also reflected in our cash position, which is detailed in the report. The main drivers for the variances against plan, as the colleagues have already talked about, are the continued operational pressures and the increased demand at both trusts, which has resulted in additional capacity remaining open, increased spend on drugs, and eradicating the corridor care at George Eliot. We've also discussed throughout the meeting the sickness rates a number of times. At both trusts, they are higher than the national average, and consequently, although we've made an impact and significant progress in reducing agency spend at both trusts, there's quite a way to go with our bank, so we are using backfill for sickness. Both trusts are working hard to ensure that we deliver our CIP programme, and financial recovery boards have been set up to ensure a continued focus on delivery of our plans. And as Adam highlighted in his Chief Exec's briefing, the planning guidance has now been issued. So this framework will start to move us away from the block contract regime back towards a rule-based financial regime. As we've just talked about, the UEC pressures and the volumes that we're seeing coming through the door, the framework will enable us to be paid at a pace of change for this activity. And the first submission is the 17th of December, with a second submission in February.
Thank you, Rafi. For members of the public, to gain some assurance, the board are all over our finances at the financial recovery boards that we have at both SWFT and George Eliot, the finance and performance meetings, all of which have occurred over the last week or so, and I've been in attendance at all of them. But clearly, a lot of work still to be done to get us to where we need to be, which is particularly at SWFT break even for this year. We had a session on this morning, but board members, any questions or perspectives on what Ravi's briefed us on? Just in terms of cash at SWFT, Ravi, just remind us as to what we did after the last board.
Yeah, in line with the national guidance, they encourage us to work within systems. So we've put in an application for a transfer of funds from George Eliot, so 7.5 million transfer. That was accepted by NHS England, and the transfer has now happened.
Okay, super, thank you very much. Okay, executive directors, again, thank you for all of those reports, and thank you for your hard work in terms of driving on a daily basis the performance of the organisations. We'll move on to then some governance issues. The first is the SWFT and George Eliot collaboration agreement, which is basically the outcome of all of the work that's been going on over the last year on the shared leadership. This is for approval. But Adam, anything you particularly want to pull out?
Nothing particular, Russell. It's a bit technical. We're currently meeting as committees in common in this board. We want to move to a boards in common, or a joint board, it's commonly called, and that means that rather than taking individual decisions for both organisations, we'll as a board be able to take singular decisions for both organisations. That also supports the work we're doing, or we've already done, to have a shared executive team, and over the next few months a shared non-executive team. This collaboration agreement underpins that work. We've worked with Mills and Reeves, our solicitors, to develop it, and as part of its implementation, we will have a twice yearly review of how the collaboration is going, which will report to board, and the next one of those will be April.
Okay, super. Thank you, Adam. So any questions or perspectives on the collaboration agreement? as I said, for members of the public watching in, we've done a lot of work on this over the last year. If you're not happy to approve, could you please raise a digital hand? Duly approved. Thank you very much. So we'll then move on to the provider capability self-assessments. Back with you, Adam.
Fairly straightforward, and indeed we've already approved this one outside of the meeting. We reported in the October board the provider capability self-assessment process, which is a process NHSE mandates all documentations to do based on the insightful board framework. Our executive directors have given an assessment, a self-assessment against each of their domains according to their own areas. We submitted these documents to NHSE a month or so ago, and so approved them virtually outside of the meeting.
Super, thank you. But I think we do just need to formally approve them now. If you're not happy to approve, could you please raise a digital hand for me? Duly approved. Then we are on, I think, to welcome in Deepa on the Swift and George Eliot Freedom to Speak Up Guardians quarterly report. Deepa, lovely to see you. Over to you.
Thank you. So I will take the report as read and just bring you a couple of points, if I may. Just to highlight, the Speak Up conference this year again was a real success, very well attended by over 100 attendees across the region, with keynote speakers talking about sexual safety, embedding change and the connection between well-being and speaking up, and all around the theme of empowering and enabling and embedding change, which was really timely given the changes that we're all going through and experiencing. So that was a real highlight for this year once again, and we'll be on to planning for next year very soon. In terms of where we've been involved more with teams and around culture, those areas for this period are radiology and community dental within George Eliot and some of the community nursing teams at SWFT. There is more detail, of course, around the particular nature of those issues involved within the report that will be discussed at confidential board. There's some concerns around accessibility from wheelchair users, and we've seen an increase in reports related to discrimination from some staff working in the community feeling vulnerable and unsafe, which might be connected with the current climate that we're seeing and increased tensions. But it's something that we just need to be thinking about and keeping an eye on more closely. In terms of casework, 27 new cases at George Eliot, so there's been an increase in reporting there. Again, the main themes are around attitudes and behaviours, incivility, relationships with managers. Some quality and safety issues as well were thematic this time round, and 23 new cases at SWFT. Again, the themes being around attitudes and behaviours, incivility, bullying and harassment, equality and diversity and discrimination. In terms of next steps, the key priorities at the current time are around getting the e-learning package for civility over at SWFT, which we've had at George Eliot for a while, and the data migration that we're currently going through from Datix to InPhase before that comes to an end, and to hopefully enable staff to self-report into that system once that's all completed. Happy to take any questions.
No, thank you, Deepa, and I'm conscious of the fact Sue isn't with us today. Can you send Sue our fondest regards, because I know
of course.
It's time. Questions and perspectives on Deepa's report, Adam?
Just to say thank you to you, Deepa, and to Sue, and also to highlight the fantastic work you did on the Speak Up conference in Speak Up Week in October. It was a great event, a great day. We had people from around the region attending, some great speakers. I know it's massively difficult to put together something like that, particularly when you're doing the day job. So thank you very much.
Thank you.
Absolutely. And Ashi?
Yeah, just going to say the same as Adam and echo my thoughts and thanks to yourself, Sue and IJ, in terms of that conference, which was amazing. From a personal perspective, it really made me reflect in terms of where we are internally in our own organisations and our culture, particularly around sexual safety. And I know that's something the other executives are really passionate about, and Fiona's put herself forward in terms of being that exec lead for that. And that's really made us think about actually where are we as an organisation, and then let's relaunch and refresh that in terms of our standards and what we expect. So thank you, Deepa, because that did really help me reflect.
Yeah, no, I think I did mention it this morning. I think it's important for us to be a safe workplace, and for members of staff who say suffering domestic abuse, they need to feel safe to be able to speak up at work and gain help as well. And if certainly they're made to feel unsafe at any point in the work environment, they need to feel absolutely that we as an organisation will support them in every regard. Deepa, is there anything more you would like us as a board to help the whole freedom to speak up culture and momentum?
Probably something that we've highlighted before, and it's just around really embedding that follow-up and feedback element of the speak up process. And it's usually the case that people go away and implement those actions and make those improvements. But if the staff don't know that that's happened, or if we as a team don't always receive the level of detail that we need to be able to, for example, give the board assurance, then that's somewhere where we maybe have a few gaps and could do with improving on.
Okay, thank you, Deepa. We'll take that on board. Okay, we'll move on then to the summary of ratified policies. Adam?
Yes, I'll take it as read. Just one for George Eliot this month, but a bumper month for Swift with 8.
Okay, any questions or perspectives of those? It's just for information. And then the board committee calendar for next fiscal year. Sarah?
Thank you. So at October's board meeting, the boards approved the dates for the future board meeting, but we needed to bring back the committee meeting dates for approval. Just to note 2 points. With regards to audit committee, the dates for considering the draft annual accounts and annual report and the final annual accounts and annual report are provisional because we're awaiting the accounting timetable. There has been some discussion this week around these dates. They possibly will change, but the rest of the dates are confirmed. With regards to the Quality Governance Committees in Common, this is bringing together George Eliot's Quality Assurance Committee and Swiss Clinical Governance Committee meetings. The dates here are for the 3rd Wednesday of the month. They've been tentatively agreed by the committee, but Fiona's got an action to take away just to make sure that that works for the operational and the governance teams. So those dates may change, but they're here for the board's approval. Thank you.
Thank you. So subject to that confirmation from Fiona, if you're not happy to approve these committee calendar dates, please raise a digital hand. Okay, duly approved. Thank you. Then we are on to the updated register of interest for both organisations, which I will take as read. Are there any final amends that directors need to make? I have to say, Ravi, I didn't know your sons worked for us. I look forward at some point to being introduced to them. Okay, so we will just formally note those. And equally on the formal notification of committee work, we've got the report from the Quality Governance Committee in Common held on the 25th of November. Sorry, getting bad feedback. Is there any comments David or Sarah would like to add?
The only one I'd like to add is that I'd like to commend the amount of work the 2 governance teams have done from the 2 trusts, actually trying their best to align all the papers. It's quite a considerable task, and they made a very good stick of it for the last meeting. I'll leave everything else to Sarah.
Super. And Sarah?
No, I would echo that. I'd just like to, just for people's assurance, you can see that there was only partial assurance for the safeguarding report. That's due to, in part at George Eliot, a changeover in our head of safeguarding. So we've said thank you and farewell to Natalie, and we've got Angela in post. She did not feel that she was able at first glance in the few weeks that she'd had with us to give us full assurance. It wasn't that she felt there was a problem, but she wanted to be able to robustly present data to us. So I just wanted to assure board that was where that was coming from, and we have an assurance that by Q4 we will be back up to that significant level of assurance. Thanks.
That's great, Sarah, and thank you. David, any questions or perspectives on that meeting and the report? Okay, we'll move on then to the audit side, and we've got the SWFT Audit Committee. Just to remind members of the public, we are combining the Quality Governance Committee, but we are keeping the two audit committees separate. First up is SWFT from the 15th of October. Robert, anything you'd like to add or highlight?
Just a small handful of things, Russell. We had a really helpful report from our internal auditors on our compliance with deprivation of liberty safeguards, and we're grateful for Fiona's attendance at the meeting and clarifying what is a fairly complex area. But it was largely there to measure our compliance. And there's some things which they're recommending, and the teams have accepted those, and we'll keep on top of those. But we're assured that the immediate recommendations are being put in place. And then a separate report on just being a little clearer and how we track and bank our charitable donations to make the audit trail on that a little more straightforward. Good progress on the aseptic service provision. That's from a previous report, and we're on course to do our annual evaluation of the external auditor, amongst other things. Just a very brief note, we had some good feedback from our governor observer just to perhaps watch our use of acronyms in NHS speak when we're going through papers. Thank you.
Wise words as ever. Any questions on Robert's audit report update? And similarly, Paul, anything you would like to add?
Just that we continue to receive reports on the joint EPR programme implementation and still remain concerned. One of the areas we were looking for more assurance on is the actual assurance process around that programme. So we're looking to commission something directly from our internal audit, and I guess we should look at the potential to read that across into SWFT as well, so it's just done singularly. But we're just waiting on the scope of that piece of work to be brought to us. We also had an initial discussion about how we might procure a single internal audit provider and counterfort provider across both organisations. And again, that's an area where we're working closely across both trusts.
Sounds all very sensible, Paul. Thank you. Any questions to Paul? Okay, thank you. And therefore we move on to the improvement board held on the 18th of November, which will take us read. Anything, Adam, you wanted to discuss?
No, just to highlight that this was the first joint meeting of the improvement board we had, and a really good opportunity actually to compare improvement initiatives across the two organisations and share best practice. I think it went well.
Super. Any questions to Adam on the improvement board? Okay, I will take the report of the Council of Governors held on the 13th of November as read, but particularly thank governors who have been involved in the recruitment for my replacement. I know as chairman of the Nominations and Remuneration Committee, Mike Flaxman in particular has had to do an awful lot of work behind the scenes. So I just wanted to thank Mike Flaxman on behalf of the organisation for the work he was involved in that regard. But any questions on that report? Okay, so we will then move on to just some notification of minutes. We've got the George Eliot Quality Assurance Committee minutes held on the 23rd of November and the 28th of October. Sarah, anything you'd like to add?
No, thank you.
Okay, any questions from colleagues? Okay, similarly, the SWFT Clinical Governance Committee held on the 10th of September and the 9th of October. David Spraggart, anything you'd like to add?
No, thanks.
Any questions to David on those? Then we've got the George Eliot Audit Committee of the 30th of September. Paul, anything you'd like to add?
No, thank you.
Any questions to Paul on those minutes? And then finally, the SWFT Audit Committee held on the 17th of September. Robert, anything you'd like to add?
Nothing to add, thank you.
And similarly, any questions to Robert on those minutes? Okay, can I thank all of the members of the committees for their hard work, and in particular the executives who are involved in producing all of the reports. I think we're on to any other business before we go to questions. Any other business, colleagues? So I think, Sarah, we've definitely had one question from Julie, which she wrote into us. Would you care to read out Julie's full question for me, please?
Yep, so Julie asks, I'd like to raise a pressing issue that I've just discovered that the integrated care team, the NHS eye healthcare checkup in ophthalmologists like Specsavers in Coventry and Warwickshire have been axed. This is devastating for people like myself with complex eye conditions. Getting an appointment at an emergency eye clinic at Coventry is almost impossible due to their triage system that is dysfunctional. The other option is to spend about £150 on a taxi fare to go to the Birmingham and Midland Eye Centre in Birmingham and wait up to 7 hours to be seen in urgent eye care. Whoever dreamed of this crazy idea of cutting the service where you could get an appointment the same day at Specsavers, which is much easier to get to, and have my eye checked out if there is a problem, and stupidity of doing this, they realise how much more congested the eye clinics are going to be and how much more difficult it would be for people to be seen in an emergency situation. I would like to know whoever thought this up and what's going to be done about it to reinstate it. Yes, you can still go to Specsavers for £25 in an emergency situation, but some people do not have that kind of extra money. I'd like to know your views on this. Please, and Julie is present at the meeting to hear the response. Thank you.
Adam, if you want to go first, and I'll give my perspective. Adam, over to you.
Thank you. Yes, we understand the concern, absolutely. But I think the first thing to say is this is not our decision. It's not a decision we took, and it's not our area of responsibility. The decision was taken by the NHS Coventry and Warwickshire Integrated Care Board. And in that decision, they decided not to renew contracts for minor eye conditions and community urgent eye services. And the reason for that they've stated is it's about use of resources more effectively and ensuring care is delivered where it's needed the most. They've also said as part of that, urgent eye care is still available, but some patients may now be seen at their GP surgery or local pharmacy instead of the high street. And medicines can be accessed via over-the-counter services or a prescription from a GP. And the eye casualty at University Hospital Coventry is remaining as the main centre. The ICB are working with GPs, pharmacists and hospital teams to support patients and will monitor the impact of the change, and they have a complaints process available through their website. I think we will also pass these comments on to the ICB. We absolutely understand them and understand the concern from Warwickshire residents, but as I say, we're not part of that decision-making process.
The only thing I would add, Julie, is I don't understand the logic of that as a decision. I think, and my wife has complex eye conditions as well. In our experience, Specsavers, and there are other optical retailers, provides an extremely effective community close to home service. And I find it very difficult to understand how that decision was made by the ICB, which appears to be almost in the opposite direction to everything that's being talked about in the 10-year plan for the NHS. But as Adam said, unfortunately, it wasn't our decision. I can only advise that you should, and I've just seen what you posted, just make sure you've emailed Simon Trickett, the chief executive, or Krishni Waring, the new chairman, because that team has now changed. But you do have our understanding, Julie, because it does seem a very, very perverse decision. Are there any other questions from members of the public who are on the line? Natalie.
Good afternoon, all. I just wanted to raise an issue about the sickness, because obviously a healthy, happy workforce is very good for patient care, and there's been a lot of discussion about that this afternoon. Is there talked a lot about what has been put in place to support staff, but are you looking at the underlying triggers? Is it any between staff having flu jabs and getting influenza? Is there anything about the physical health of staff and them getting musculoskeletal injuries? Are you going back a stage further to triangulate what's happening?
There's an awful lot going on in terms of trying to gather evidence, Natalie, because it is a big concern. And I think one of the things that concerns the board is it doesn't become almost a cultural norm that if you're not feeling great, you don't go into work. And that's quite a difficult culture then to end up getting into the right place. But I can assure members of the public that there's a lot of work going on and will continue to go on, because we do need to turn the trends, as Ashley was indicating earlier.
Thank you for that. I just wanted, on behalf of the Patient Forum, to send our season's greetings to everybody, and hopefully staff will manage to get a good break over the Christmas period. Thank you.
Well said, Natalie. And any other questions from members of the public? Well, this is my last Christmas board that I will be giving for Swift and George Eliot. So I just want to wish everyone who's on the call and those who maybe listen to the call later a very happy and blessed Christmas, and to remember that there will be members of your community who suffer enormous loneliness at this time of year, particularly if they've lost a loved one and this is their first Christmas on their own. So I just encourage members of the public to reach out to people in their community that they know might be going through a particularly tough time. Christmas can be a very happy time, but it can also be a very lonely time. As Adam indicated earlier, and Fiona popped into the chat box, if you haven't had your flu jab, we really do very strongly recommend you do so. And when it gets icy, make sure you've got the right boots on so you don't slip over, and don't be afraid, like I do nowadays, to walk around with a stick to make sure that if I do slip, I've got a better chance of standing up. Take care, everyone. Look forward to seeing you soon. To board colleagues, we'll have a 10-minute break and get back together again at 3:25. Thank you. Bye.